Hey everybody, and welcome back to my channel. Today we're going to be talking about interstitial lung disease. Okay, so what is interstitial lung disease? Basically, it's parenchymal pathology that causes fibrotic changes, right? Fibrosis. But oftentimes there is alveolar and airway affection. So interstitial lung disease is a little bit of a misnomer, right? So that's the pathology here. Now let's talk about, ouch, sorry about that. Let's talk about the etiologies. Right, so I'm going to divide them into three broad categories. This is my own classification, the way that I remember it. I hope you all find it helpful. So there's there's inhaled, right? There's iatrogenic, and there's systemic association, right? So in inhaled you have inorganic and organic. Among inorganic you get things like silica and beryllium and asbestos, right? Your pneumoconiosis and stuff. In organic you get hypersensitivity pneumonitis, right? Among iatrogenic, you get drugs and radiation, which is also known as radiation pneumonitis. Pneumonitis, which is like basically chemoradiotherapy or radiation therapy for certain types of cancers. And among drugs, you have azathioprine, you have methotrexate, you have busulfan, you have bleomycin. There are actually like a ton of drugs that can cause this kind of pathology in the lungs. The list is actually quite exhaustive. It's almost like 300 plus medications that they have identified that cause ILD, but obviously we're not going to go into all of that. Another important one would be amiodarone. You don't want to miss that. And then there's illicit substances like cocaine, heroin, right? Now, let's talk about how your ILD would present, right? Presentation. Now, it presents with, first of all, it presents with progressive breathlessness, right? It gets worse over time, and it causes non-productive cough, and this is persistent, right? They're just always going to be coughing, but they're not going to have sputum, so it's like dry cough. And they're going to have exercise intolerance. They're going to have what you call dry crackles and Velcro-like sounds on auscultation, right? Auscultation. They're going to have, let me see. I mean, it's just basically all going to be related to the pathology that you're seeing in your lungs. And one of the things that can also happen is that if it is associated with diffuse alveolar hemorrhage, they're going to have hemoptysis. Like if it is associated with diffuse alveolar hemorrhage. And in special cases like idiopathic pulmonary fibrosis or um, in asbestosis, you're going to see digital clubbing. Very uncommonly, they can have wheezing and chest pain, but I'm not going to write that down because I don't want to confuse you, because that's not a very common presentation. So you want to sort of differentiate your dry crackles from wet crackles, right? So wet crackles happen when you're having pulmonary edema, basically, right? So wet crackle is more like a gurgling sound, whereas dry crackles are basically if you take some hair between two fingers near your ear, and if you rub them together, that's the sound that you should be hearing with the interstitial lung disease. Okay, and one of the things that I want to elaborate on with exercise intolerance is that one thing to remember with interstitial lung disease is that this is a diffusion limited situation, where, for example, if you take partial pressure of oxygen along this axis, and you take distance along the alveolar capillaries on this axis, and this is the oxygenation of the alveoli. In a normal patient, the oxygenation is going to go like this, right? In the beginning it's going to be less, but as it goes through the alveoli, because of the way that hemoglobin functions, once it binds one molecule of oxygen, the affinity for it for oxygen rises 100-fold, and as it passes through the capillaries, it's going to be like, almost like it's going to have the same graph as that of the alveolus. Now, if this in a diffusion limited condition, it's going to look more like this. This is what abnormal looks like, right? And when they say exercise intolerance, first of all, there is this inability to reach good oxygenation, and on top of that, when they start to exercise, what's going to happen is that your body is pumping blood at like a faster rate, right? So it's giving your capillaries even less time to sort of extract that oxygen from the alveoli, and that's why they end up getting more and more breathless with interstitial lung disease. Okay, so let's move on to diagnosis. This is going to be, I don't know if I should let you think about it, but it's pretty straightforward. This is going to have a restrictive picture. Let me just change the color just so that you feel a little bit more comfortable. Otherwise everything just starts to merge together. So on spirometry, right, they're going to have a restrictive picture. So what does this mean? They're going to have low lung volumes, right? And they're going to have a normal / increased FEV1 by FVC ratio. Now this is the forced expiratory volume in 1 second divided by forced vital capacity. So what happens in interstitial lung disease is that your FVC is reduced by a lot because you have low lung volumes. But your FEV1 doesn't reduce as much. The reason why this happens is that because there's fibrotic changes, there's going to be radial traction on the airway, and that sort of increases the expiratory flow rate to some degree, and that is actually why the reduction in FEV1 is not as much, and this is why it ends up being normal slash increased. And if you do like the DLCO test, which is the diffusion capacity of the lung for carbon monoxide, it's going to show decreased, because this is a diffusion limited scenario. If you do a VQ test, there's going to be like insufficient ventilation, but the perfusion is fine. And DLCO, you're going to see like reduced carbon monoxide diffusion capacity for carbon monoxide. Now on imaging, let me just, yeah, on imaging, you're going to see that on chest x-ray they're going to have patchy and reticular bilateral opacities, and on a high resolution CT of the chest they're going to have something called honeycombing, and what we call traction bronchiectasis. Okay, now moving on. How do you go about managing a patient with interstitial lung disease, right? Obviously, I guess it goes without saying, first thing you want to do is manage comorbidities. Now, and then there's going to be pulmonary rehab. Another thing you want to see here is that the meds that are used here, first of all we have steroids, secondly we have anti-fibrotic meds, and then immunosuppressants. Now, among antifibrotic drugs, there are two main ones that you will want to remember for the boards. Those are nintedanib and pirfenidone. And the mnemonic that I use for these two drugs is sorry about that. Nintendo is pure fun. That sort of helps me remember nintedanib and pirfenidone. But the catch with these two medications is that you have to first of all do your LFTs, because both of these tend to be hepatotoxic, and you have to have good baseline renal function, because if this isn't good, because these two to quite a degree they depend on renal excretion. If your baseline renal function is not good, they can end up accumulating the drug and causing more toxicity, right? And among immunosuppressants you have a bunch like rituximab and tocilizumab and that kind. Now, so you managing the comorbidities, you're doing pulmonary rehab, you have your medications. One important thing that you have to remember is that over time these patients can become hypoxemic at rest, and that is when you will have to go for LTOT, which is long-term oxygen therapy, long-term oxygen supplementation. This has been shown to sort of decrease the incidence of pulmonary hypertension among these patients. And one very important and high yield thing to remember is that they need vaccines. So your lungs in interstitial lung disease are already in a compromised state. So what happens is that if you suffer some infectious disease of the lung, the chances of decompensating at that point are very high. So you want to get out ahead of it and give them these vaccines that I'm about to mention. I'm going to divide it into bacterial and viral, just so it's easier for you to remember. So among bacterial, you have pneumococcal, and pertussis, right? And among viral, you have flu. The killed flu vaccine has to be given every year. And then there's the COVID-19, which is given in 3 doses, and 2 doses and 1 booster, right? And then there's going to be RSV, especially if the patient is more than 60 years old, right? So now it's important to manage this condition, right? If you don't, they can end up with some very unfortunate outcomes with this pathology. And the first one of those is going to be pulmonary hypertension, and it can also progress to cor pulmonale or pulmonale. So that would be the natural history of interstitial lung disease if it goes like untreated for very long. And another thing that you want to remember, I think one of the associations that I forgot to sort of expand on the systemic causes, right? So one of the biggest ones is going to be sarcoidosis, and then there's going to be autoimmune diseases like SLE, diffuse cutaneous systemic sclerosis. Then you're going to have, I'm sorry about the confusion. Then you're going to have Sjogren. You're going to have dermatomyositis and polymyositis. Then there's going to be Churg straws. There's going to be granulomatosis with polyangiitis, or previously what used to be called Wegener's granulomatosis. So SLE, systemic sclerosis, Sjogren's, these are some of the autoimmune conditions in which they do test interstitial lung disease in association with these disorders and all these vasculitides. So I hope this was helpful, and I hope that I've made things clear for you all with respect to interstitial lung disease. It's actually a very broad topic, right? There's like tons to touch upon in this topic, and I hope I've done a good job of like sort of condensing everything you need to know, right from the basics till the clinical stuff, like what all you need to remember. I mean, IPF in and of itself is a huge topic, which I'll probably like if I wanted to address that, I would maybe make a separate video. But this, I think, sort of gives you a good overview of everything that comes under ILD for the boards. Thank you so much for listening. I hope you guys enjoyed this video and learned a lot. I will see you guys next time.